categories of host responses is that we can think of the response as being along a continuum. So the host response could be an adaptation to the stimulus. For example, analogous to a tree kind of swaying or blowing in the wind. Or it could be a reversible injury where some of those branches, for example, as an analogy, some of those branches on the tree are broken off, but the tree survives. Or we can categorize these host responses as irreversible. The damage has been done. It's not naturally going to take care of itself. So I've shown like how when there's a reversal, this would be like if the whole tree were uprooted or something and the tree dies. So we're going to see these different host responses can fall along this continuum from something just being an adaptive change to a reversible injury. It can go back to normal to something that at the other end is irreversible. So the categories include developmental anomalies, retrogressive changes, disturbances of growth, neoplasia, circulatory disturbances, and inflammation, the latter of which is going to be a complete separate topic. Okay, let's look first at developmental anomalies. These occur during our development, and by natural causes, they're irreversible types of injuries. So let's distinguish among these three types of developmental anomalies. An anomaly is simply a deviation from normal. First of all, malformations are an alteration in the normal shape or structure. So those thalidomide babies with their stunted limbs, their seal-like limbs, or a club foot. Spina bifida can lead to a whole variety of malformations. Even just this in the oral cavity, even just this little, here's an example of fusion of two teeth, a primary central with a primary lateral. That is classified as a malformation. Or again, the most serious that we've talked about is the bilateral cleft lip with cleft palate. That's not a normal lip or palate development. It's a malformation. So it's just showing you something that's not very severe to something that's very severe. Okay, when you see the root word plasia, this is going to come up in a lot of the host responses. That the word plasia translates as growth or development. And we can use the term aplasia means without growth, or also agenesis means that something doesn't develop. It could be a tissue, it could be an organ, or a complete body part that doesn't form. Severe congenitally missing teeth. This patient's maxillary laterals never developed. I've already mentioned how congenitally missing third molars is also very common. One or two, three, or all. Here's a missing bone. Here's a patient who has what's called aplasia or agenesis of the clavicles. So this person can move, because there's no clavicles, they have ability to touch shoulder to shoulder. And this is seen in a disease called cleidocranial dysostosis. So this is showing you an entire bone that's absent. And let's go next to hypoplasia. So hypo, if we go to that, means undergrowth, okay? It doesn't develop fully. I didn't say it didn't develop at all, it just doesn't develop fully. Or another way of saying it, we can say that the tissue, the organ, or the body part is smaller than normal. Hypo, underdeveloped. So here's an example of an underdeveloped mandible. You know, this could be genetic in nature, or it could be that the person had an infection in the TMJ area that stunted the normal growth of it. You know, this hypoplastic mandible contributes to a class 2 malocclusion. And a lot of times these patients with a hypoplastic mandible will actually have orthognathic surgery, where part of the surgery is breaking the jaws and kind of repositioning it. Here's hypoplasia at the tooth level. Here's a third molar present, but it's not its normal size. It's classified as a microdont tooth. A peg lateral would fall under that as well. And then again, hypoplasia at the tissue level. Here's an underdevelopment of the enamel. The ameloblasts were disrupted during the tooth development. And you can see in these sections, there's missing enamel there, underdevelopment in each of the teeth shown in the anterior area. And I hope you can see that these are irreversible injuries that can only be fixed by interventions like surgeries. Okay, let's go next to the group that's classified as retrogressive. So these are host responses where the tissue, organ, or body part develops normally, but it's said to regress because of the injurious stimulus. So these fall along that continuum that I mentioned. Atrophy is an adaptive response. Degenerations at the cellular level are reversible injuries. I'm just going to highlight them briefly. And then necrosis, which is tissue death, is an irreversible injury. Okay, so in general, atrophy just means that it's an acquired decrease in size. Okay, it was once of normal size, but then it becomes smaller because of the injurious stimuli, and a wide variety of body parts are subject to atrophy. You know, this is different from hypoplasia that never reaches full development. Atrophy is, there was normal development, but then there was this regression or this decrease in the size. Atrophy can be classified into two main types: general, involving widespread tissues in the body, and local, confined to one area, part, or tissue. And on your outline, it has them defined and grouped in this manner. And the two that fall under general atrophy are what are known as starvation and senile atrophy. And then under local, we're going to talk briefly about disuse, neurotropic, pressure, and endocrine atrophy. And then some applications that don't necessarily fit into these categories, but the term atrophy is applied. Okay, so let's, I just want to show you that some of these are a little bit graphic pictures, so I just want to prepare you for that. Okay, starvation atrophy. There's a disease called marasmus, where there's a deficiency of calories and nutrients. And this is what can happen in some of those third world countries in which famine is prevalent. And then there's also what's called kwashiorkor, where what happens to these children is they have more of a protein deficiency, and they'll look like they're wasting away, but because of disruptions in the normal fluid balances, due to protein deficiencies, they develop edema or swelling in the abdominal area. And then, anorexia, where again, the person has a condition where they're not getting enough calories and nutrients, and you can just see the wasting away of the individual in this photo. So those are examples of starvation atrophy. Okay, senile atrophy is just as one ages, there are many different tissues that do atrophy. And part of it may be due to when the circulation is diminished with age, the tissues aren't being as oxygenated. And the overall host resistance is diminished to some degree. It's named senile atrophy because of proof that the brain can reduce in size. It doesn't mean everybody's going to become senile with senile atrophy. It's just the term that's applied because the brain is one of the tissues that has been proven to atrophy with age. What are some other tissues besides the brain? The skin atrophies, the oral mucosa, is subject to atrophy. Tonsils, usually in children and young adults. Tonsils are easier to see during the oral exam. Muscle, bone, breast tissue. So there's quite a few tissues that atrophy with age. Okay, let's look now at the different types of local atrophy. So first of all is disuse atrophy. Anybody who's had an arm or leg immobilized after a fracture can probably relate to this. When you first take the cast off, you may see that there has been some atrophy of one of your arms or legs, as shown on the right-hand side. So it just means from not using the body part, it becomes smaller in size. Once full function is resumed, it can, go back to normal. Okay, neurotropic atrophy is classified as a type of disuse atrophy, but it's because of not inactivity per se, but there's lack of the nerve stimulation to the different muscles that leads to their atrophy. And there are many different types of neurotropic atrophy. Some of the more common ones would be like carpal tunnel, Bell's palsy. So let's look at here with Bell's palsy. There's been damage to the motor root of the facial nerve so that the muscles of facial expression are paralyzed and they atrophy. Here's another. Another example would be like if a stroke victim would lose the neurologic stimulation, and you can see one of these, this leg is smaller on the patient's right. I mentioned carpal tunnel, when there's restriction to the nerve that goes through your wrist area into the hand, and it's just kind of showing you this hand muscle that's weakened and atrophied in the process. And this is a risk from repetitive motions, and in our profession, there are people that are at risk for developing carpal tunnel syndrome. ALS, here's where patients have degeneration in their neurons, and so they have atrophy. You may have heard of the famous scientist Stephen Hawking that recently died from this disease. He actually lived quite a long time with it, but that's, again, this atrophy of muscles is related to neurologic loss of neurologic stimulation. And then back before our time, there were individuals that were affected by polio, or the virus that causes polio would damage the nerves, and this was, you can see the atrophy of that person's leg. Okay, so there are several applications of neurotropic atrophy. More common would be carpal tunnel and Bell's palsy. Pressure atrophy is, as the name implies is related to prolonged or steady pressure on a tissue. A common example is when patients are bedridden, they have to be moved around because constant pressure on different areas of their skin can lead to bed sores or ulcers. There's atrophy of the skin. There's a close-up of a really bad one on an individual. An pressure atrophy is when someone has glaucoma, increased eye pressure. There it can affect the retina and cause its atrophy, and it can actually lead to blindness if it's not treated. So the pressure from the fluid on the retina as seen in glaucoma can lead to pressure atrophy. And then this is just an example of some kidneys that had shrunk down. For example, a person could have a tumor, and the pressure from the growing tumor can actually cause atrophy of the normal tissues. So for example, if there was a renal tumor or a kidney tumor, as it's growing, it could impact or lead to a decrease in the size of the kidney that it's affecting. And then I don't know if this is really still done, but I had students previously that raised horses and trained horses, and they told me that they actually would use pressure atrophy to castrate animals. Like they would put like rubber bands on the genitals of horses so that they were no longer stallions but geldings, that type of thing. I'm not really sure if that's how it's done anymore, but I do remember, years ago them sharing those stories about that, which is interesting. Okay, and then finally, there's what's called endocrine atrophy. And this is the pituitary gland is our master gland, and it's going to stimulate other areas in the body to produce hormones as well. And sometimes when there's a lack of hormonal stimulation, that can lead to a decrease in the size of different areas. And so, for example, common ones that are affected by endocrine atrophy are the thyroid gland. There may not be getting enough thyroid stimulating hormone, or the adrenal cortex. That area is not getting adrenocortico-stimulating hormone, possibly. And then just some of the reproductive tissues, like the uterus, may not be getting the normal hormonal stimulus, and it shrinks down. Okay, so as you can see, there are a wide variety of different classifications of atrophy. And here's an application where it doesn't fit into those categories that I mentioned. It's more like a nutritional atrophy, because when the filiform papillae are missing again, I know I keep showing this iron deficiency anemia, but when the tongue has a smooth, bald appearance with a decrease in the filiform papillae, the term atrophy is applied. Also, some patients that have geographic tongue have atrophy of the papillae in these reddened areas. And the reason is not entirely clear. Whereas the one on the left is clearly related to nutrition. There's what's called atrophic candidiasis. This is a fungal infection which causes atrophy of the oral mucosa and a redder appearance. And then there is I'll move this. There's what's called Plummer-Benson syndrome, which is actually related to iron deficiency. And not only does it cause the atrophy of the tongue, but just the oral mucosa in general, and can affect the esophagus as well. So there's an atrophy of oral mucosa and the esophagus as related to an iron deficiency. And unfortunately, individuals that are diagnosed with this are actually are predisposed to oral and esophageal cancer. Degenerations. Okay, last week I mentioned different degenerative diseases that can affect many different organs, such as our brains, our bones, and so forth. In this case, the application of the term degeneration refers to cellular alterations. These are changes that are seen at the cellular level, so they're only seen under the microscope. They're classified as reversible injuries, because if we take away the stimulus causing them, the tissue can return to normal. And usually in a general pathology class, there's like a whole chapter on this. I'm just going to give you a couple examples of the more common degenerations. Okay, so I'm going to there's what's called albuminous degeneration, or what's known as cloudy swelling, hydropic degeneration, and fatty degeneration. Okay, albuminous degeneration is generally caused by the following. I'm just giving you a couple, like if certain infections, fevers, toxins, poisons, and severe burns can all lead to this type of degeneration that's seen at the cellular level. And it gets its name because there's an abnormal accumulation of protein in the cells that actually affects these cells. And if it continues, if it just doesn't go away, it can actually lead to death of those cells. And then what can happen because of cloudy swelling is the protein granules attract fluid by osmosis, and there's what's called hydropic degeneration. Cells here that have an abnormal accumulation of water, hydropic in the cells. So the same causes for cloudy swelling can lead to the hydropic degeneration. More fluid, more protein granules in cloudy swelling can attract water, and then it becomes hydropic degeneration. And then another common degeneration is what's called fatty degeneration. This is what can happen to the liver from alcohol consumption. It can be what's called a fatty degeneration of the liver, and it can be reversible. Take away the stimulus, and then the liver in some cases can return back to normal. So again, these are all, you don't have to know the microscopic picture or anything. Okay, so atrophies are adaptations. Degenerations are reversible alterations at the cellular level. And then finally is necrosis, which is irreversible. So this is uh, when the tissues die or the cells die, and some of the injurious stimuli for necrosis include trauma, infections, microorganisms, poisons, and alcohol could be classified as a poison in this case. Like fatty degeneration can actually progress to death of cells in the liver with scarring, and that's when a patient has cirrhosis of the liver. And lack of nutrients or blood supply will lead to necrosis. So, for example, the heart muscle will die if the coronary arteries are blocked. Okay, there are three main types of necrosis based on the physical characteristics of the dead tissue. Again, you don't have to know the microscopic picture, it's just for illustration. So the three main types of necrosis are coagulative necrosis. This kind of looks like a coagulating egg white, or when you fry eggs on the stove, the proteins in the tissues coagulate. Then there's what's liquefaction necrosis. Instead of being semi-solid, like a cooked or fried egg white, the tissue liquefies. It's in a liquid state. And then caseous necrosis refers to a type of necrosis that has it's just like if you left cheese out for a couple days and you picked it up, it would be what's called friable, meaning it crumbles and breaks apart, doesn't hold together. So all three of these are all based on their physical characteristics. So when does coagulative necrosis usually occur in the body? It's usually what happens to most of our tissues in the body if they're deprived of oxygen. So anoxia would be the injurious stimulus. And the best example is what happens to the heart muscle during a heart attack. The coronary arteries are blocked, no oxygen is getting to parts of the heart muscle, and the heart muscle will die. Not on your sheet there. I just wanted to mention there is a subtype of coagulative necrosis. If you just would write this in, please. And what happens here is coagulative necrosis occurs, but bacteria decompose the necrotic tissue. And this is what can happen. A person I've mentioned before with diabetes has circulatory problems. So different limbs may not be getting sufficient oxygen. And the coagulative necrosis occurs, and then the bacteria come in and they can be developing gangrene. And you may have heard of some individuals with uncontrolled diabetes may have to have a foot or a leg amputated because of this gangrenous necrosis that has set in. So it's just coagulative, which is superimposed with bacteria. Okay, let's look at some examples of liquefaction necrosis. I mentioned that when most tissues in our body are deprived of oxygen, they would undergo coagulative necrosis. The brain is the exception. For example, like during a stroke, if they have a type of stroke where the oxygen is cut off to the brain, what happens is the brain actually can undergo liquefaction necrosis. So that's kind of one of the main exceptions to the rule. Some less serious forms of, well, they can be life-threatening too, but some more common types of liquefaction necrosis are just when you have pus form. Purulent exudate means pus. And why is this classified as necrosis? It's because pus is actually made up of dead and dying neutrophils, those white blood cells that come to our defense. And we get this liquid, yellowish green liquid that appears in the area. So if you have a pussy zit, there's liquefaction necrosis going on there. In the oral cavity, the pulp there can be a intrapulpal abscess that we can't see on an x-ray, but what can happen is we can get abscesses at the apex. They can spread, they can travel through a fistulous channel out to the surface. Here we can see the pus there. Sometimes they'll even spread to the face area. Here's sometimes in periodontitis, we'll see this pus coming out of a periodontal pocket. So liquefaction necrosis in the pockets or in different abscesses in the oral cavity are an oral application. And then tonsils can produce, in the tonsils, pus can be produced when someone has tonsillitis. So here are some pussy tonsils shown. Okay, and then lastly, here's at an autopsy, here's the caseous necrosis of the lungs, and this type of necrosis is basically seen in tuberculosis. It's kind of special to tuberculosis, but it has that dry, cheesy, crumbly look to it. Okay, so those are the basic forms of necrosis that are defined according to the physical appearance of the dead tissue. All right, let's look at disturbances of growth. Okay, what falls under disturbances of growth are hypertrophy, hyperplasia, and metaplasia. And all of these are adaptive, reversible responses. The cells are normal, but they have this increased functional demand on them. So they change in certain ways. But in every case of these, as I go through each of them, as I distinguish among them, the cells are normal. In contrast to neoplasia, which is in a separate category. Okay, so let's first look at hypertrophy. So here we see an increase in the size of an organ due to an increase in the size of its component cells. So if I just show two cells, And what happens in hypertrophy is they enlarge, which overall increases the size of the tissue. And this best applies to muscle tissue. It can be skeletal muscle. So weightlifting leads to hypertrophy of our skeletal muscles. But it also can include cardiac and smooth muscles as well. So this is back when Arnold Schwarzenegger was Mr. Universe, many, many years ago, but all this weightlifting led to hypertrophy of his skeletal muscles. And that's how he is today, or recently. From not weightlifting, it can reverse itself. It's a good example to show up when you stop this, it will revert itself. Dental application is there are some patients that are clenching or grinding their teeth. There's overactivity of the masseter muscles and they can become very prominent. You may be doing some extraoral palpations and notice that there's this hypertrophy of the masseter muscles. Here's just someone that has the hypertrophy, and then they had some surgery actually to reduce that afterwards to show that. Okay, there's also of the heart muscle. If the heart's not pumping properly, it may try to, it'll try to start making more muscle to try to pump harder. It's really, this is one of those things that's generally classified as idiopathic. It doesn't really have an exact cause, but the heart muscle really enlarges to try to just compensate for the heart not pumping properly. It can apply to like the smooth muscle of the uterus. So like in pregnancy, there's going to be more of a hypertrophy of the smooth muscle lining the uterus. And then also the term has been used has been applied to the filiform papillae as well. When there's an overgrowth of the filiform papillae, they become more heavily keratinized, they're said to have hypertrophy. So this is not related to muscle, but it's just another application of the term. Okay, next is hyperplasia. There's that term, plasia, growth again, and hyper would be overgrowth. So what happens is in hyperplasia, if we had two cells and then we get more cells, and overall the tissue gets, I'm not drawing very well, but the tissue gets bigger because of an increase in the number of its component cells. So hypertrophy, the cells get larger. Hyperplasia, more cells are produced. And I want to stress that, and it's written on your outline, that often these two occur together, both hypertrophy and hyperplasia. So when I mentioned during pregnancy that there's actually enlargement of the uterus, and it could be related, it's known to be related to not just hypertrophy, but also hyperplasia. So often it's hard to just separate the two because they do occur together. Again, I just want to mention when a tissue is hyperplastic, the cells are normal. there's a normal tissue arrangement, and even though the size gets larger, overall there's a limitation to that growth potential. If we take away the stimulus causing it, it's going to stop growing. Okay, so it's an adaptive change, and we take away the stimulus, it can return to normal, or it can shrink down to a degree. Sometimes these areas of hyperplastic tissue don't shrink back down to normal 100%, and these may have to be surgically removed. But this is an important uh, characteristic, that they typically have a limited growth potential. So just a couple examples. If you had one kidney, there'd be a greater functional demand on your other kidney that it could enlarge. Again, it may be a combination of hyperplasia and hypertrophy. And I already mentioned about hyperplasia and hypertrophy of the uterus during pregnancy. It also can apply to breast tissue. Uh, Goiter is enlargement of the thyroid gland. Goiters can occur, it kind of gets confusing, but it can from an underactive thyroid. It's trying to compensate and enlarges without being effective. And here's just two examples. Again, the extreme ones frequently get published, but this would be like more commonly what you would see. Or this enlarged thyroid could be a result of a hyperthyroidism. In both cases, it can occur. During infections, we're said to have hyperplasia of our tonsils. Or this, remember the lingual tonsils in the base of the tongue, they can extend over on the posterior lateral borders, and they can actually become hyperplastic. Now, one subcategory I'd like you to write in is, sometimes you'll hear the term connective tissue hyperplasia, or what's called fibrous hyperplasia. And in the oral cavity, there are many applications of this. And let me give you a couple minutes to record the definition. So this is an increase in the size of the organ due to an increase in the connective tissue elements. It doesn't necessarily just mean the cells, the fibroblasts that are found in the connective tissue, but the products. So extra production of collagen fibers, for example, which causes enlargement. And after you record the definition, I'm going to go ahead and show some oral examples of this. Okay, so earlier I showed how the drug Dilantin can lead to gingival enlargement. Originally, they called it hyperplasia, but they found by studying it more closely, it's also an enlargement of cells and an increase in the number of the connective tissue products. So today you'll hear more of the term not gingival hyperplasia, but just gingival enlargement. There's an inflammatory gingival enlargement that's when someone is pregnant, there's can be an exaggerated response to local irritants like plaque and calculus, forming these localized gingival enlargements, and they're referred to as a pyogenic granuloma or pregnancy tumor. And pyogenic granuloma can occur in individuals who are not pregnant as well. But this is one of the more common type applications of connective tissue hyperplasia. There's a lesion that's related to trauma or local irritants. The fibroma is actually not really, as the name, the word fibroma denotes that this is a tumor, but most of them are just areas of hyperplastic fibrous tissue. Very, very common oral lesion. And then I showed you this earlier. This is like a fibrous overgrowth, connective tissue hyperplasia related to an ill-fitting denture. The border fits right in there, and on either side we see these hyperplastic areas of connective tissue. And then another application is some individuals, and there can be a ethnic or genetic predisposition, is what are called keloids. Keloids are connective tissue hyperplasias or excessive scar tissue. So this person got a piercing and had this excessive scar tissue. Here's keloid formation from this oral piercing. Here's just some, from here's a keloid, and this is just a very extensive keloid on that individual, but it represents hyperplastic scar tissue, which is loaded with collagen fibers. Okay, so the next one is metaplasia. And here we're not going to see changes in the size of the cell. We're not going to see changes in the number of cells, but we're going to see a change in the cell type. Okay, the cell type to which it changes is still considered a normal cell type. And I'm going to give you two very common examples of when this occurs. Okay, there's what's called squamous metaplasia of the respiratory tract. Okay, you already know the oral cavity is lined with stratified squamous epithelium. But the rest of the respiratory tract is lined by what's called pseudostratified ciliated columnar. And what happens with smoking, the injurious stimulus is smoking. What happens is this kind of epithelium converts, here's our pseudostratified ciliated columnar, and it converts to a stratified squamous. This is an adaptive change. This is a tougher, even quote unquote protective type of epithelium that forms in response to smoking. If the person stops smoking, it can return back to the normal pseudostratified ciliated columnar epithelium. So squamous metaplasia in the respiratory tract of smokers is a very common application of the term. Okay. The second example I'm going to give you is what happens as a consequence of acid reflux or GERD, when there's this chronic regurgitation of stomach acids in the esophagus. Okay, what happens is the esophagus, like the oral cavity, is normally lined with stratified squamous epithelium. And it changes to a glandular epithelium. It's like the type that's seen in the stomach or the intestines. Okay, so we get this change due to chronic regurgitation of stomach acids. And with this type of metaplasia, the condition is called Barrett's esophagus. If this chronic exposure to stomach acids is resolved, the tissue, the esophagus can reverse and change back to normal. So the point I'm making is that these are still normal types of tissue changes, and they're reversible. But at some point, they may progress to premalignant changes and malignant changes, which means cancer in both the smoking situation and the acid reflux situation. Okay, and I'll show that association momentarily. And that leads us to the next type of host response, and that's neoplasia. When you just take that word, we're going to have a separate unit on neoplasia, but I'm just going to introduce the term here. Again, plasia means growth. This translates as a new growth. But what's different is the cells making up this abnormal growth, this growth are abnormal. So what happens is the genetic material in our cells is triggered to change from normal to abnormal. And we end up getting these different growths that are independent and not regulated by our are normal cell controls. And so when neoplasia develops, we'll see benign or malignant tumors form. So in both benign and malignant tumors, malignant being cancer, the cells are abnormal. There's been a change in genetic material. And if neoplastic growths are not treated, they have unlimited growth potential. Even if the stimulus that triggered them is taken away, these types of growths just will keep growing and growing and growing. In contrast to, hyperplasia and even metaplasia. So when we develop benign or malignant tumors, it's beyond the functional demands of our tissues. It's not an adaptive change. There's no purpose for it. And so we're going to have, like I said, a whole topic on introduction to neoplasia, and then later on in the course, we're going to talk about many benign and malignant tumors that affect the head and neck area, including most oral cancer. I had shown you this the other day, that neoplastic diseases are characterized by benign and malignant tumors. And tying this in with metaplasia, up there it just says the distinction between metaplasia and neoplasia. So here's normal, and if there's an injurious stimulus, for example, smoking or acids from the stomach, leads to metaplasia. If we take away that stimulus, the tissue can return to normal. If that stimulus continues, we can actually go to, I didn't mention dysplasia yet, but dysplasia, just for right now, suffice it to say it means pre-malignant changes. Still can reverse itself, but once it goes to neoplasia, this is where I said there's been a genetic change in the cell types from normal to abnormal, and that's not reversible. We treat neoplasia, but with different treatment modalities, but in itself, it's not reversible. So those are the disturbances of growth, hypertrophy, hyperplasia, which often occur together, the metaplasia, and its distinction, and their distinction from neoplasia. Okay, let's wrap this topic up with some discussion of circulatory disturbances. And this is going to be just more of a general overview. Like I mentioned before, this is not a systemic pathology class. We're not going to be studying all of the cardiovascular diseases. So just some more of a general application of some important terms. Okay, so everybody has had a cut before in which they may bleed a little bit, and any kind of internal or external discharge of blood is defined as a hemorrhage. And again, the consequence depends on the amount of blood loss. It can be very minor or it can be life-threatening. The person on the right is that patient with hemophilia, that genetic disease where they are prone to abnormal bleeding in joints and even when there's trauma to the oral cavity. The next two terms, edema and hyperemia, we're going to see are part of an inflammatory response, but I just want to show that they can occur outside of inflammation as well. Edema just means excessive fluids in the tissue. This shows a person that has edema in the ankle area. This may be a common manifestation of congestive heart failure. The heart's just not pumping the blood properly, and the fluid dynamics in the body changes such that excessive fluid in the tissue accumulates. So this, when in congestive heart failure, this edema is not part of inflammation. In gingivitis, there's edema, and then this is inflammation. So this is just showing you that excessive fluid in the gingival connective tissue leads to bulbous and spongy tissue. Okay. Hyperemia. Hyperemia can be physiologic or pathologic, part of the inflammatory response. It simply means a localized increase in the volume of blood. It can be active, where there's more blood being pumped into the area, or it can be passive, where blood is not outflowing as well, leading to a net increase in volume of blood to an area. Physiologic active hyperemia is what happens when someone blushes. If I were to embarrass you, I know we're not in a classroom situation, but if I were to, which I wouldn't do on purpose, but if I embarrass somebody, some of you might turn red and your face may seem flushed. This is just like a physiologic reaction. That's a result of more blood going to the skin of the face area. In inflammation of the gingiva, there's a hyperemia, increased volume of blood to the tissue that leads to the redness of the gingiva. So this illustrates how hyperemia is part of the inflammatory response. Okay, this next part I had posted a few of the slides that had the pictures on them that were more detailed. You may or may not have seen them. And the rest of these terms are closely related. They can be confused, so I just want to take this go through this, uh, so that you just have this understanding of it. Does anybody know if that's somebody else that's using somebody else's computer that's trying to get back in the class? Okay, the first term to distinguish is a thrombus. The plural for thrombus is thrombi. A thrombus is shown on the right. What it is, it's when blood clots within an intact blood vessel. So here's the blood clot within an intact blood vessel. Why does a thrombus develop? Why does a thrombus develop? And again, you don't have to write this down because, like I said, it's on the slides that are posted. If you just maybe try to listen for right now, if you didn't print that out. And this is just because there's abnormal blood flow in the blood vessel that leads to activation of our coagulation system, that clotting cascade that you may have learned about in A&P. So we have this abnormal slowing down of blood, hemostasis, and the blood can clot. The process of the formation of a thrombus is called thrombosis. So the process of a thrombus forming is thrombosis. So this is illustrating thrombi in the coronary arteries to the heart. Here are the thrombi. The process by which they have formed is called thrombosis. Unfortunately, there are negative consequences of thrombosis. And the consequences of thrombosis include infarction. Because what happens is these blood clots obstruct our arteries or veins. The normal oxygenated blood supply is cut off. So in other words, there's anoxia, no oxygen getting to the tissue, that leads to infarction. In other words, in the case of the heart, a myocardial infarction is a heart attack. And the infarction is the formation of an infarct. That's the process. So then what is an infarct? An infarct is an area that undergoes necrosis following cessation of a blood supply. And remember, when in most tissues, including the heart, when there's no oxygen getting to the tissue, the type of necrosis that occurs here is coagulative. But this area of coagulative necrosis is specifically called an infarct, right here. Here's your infarct. And the process by which it forms is called infarction. So again, thrombosis cuts off blood supplies to arteries and veins. There's lack of oxygen and death of tissue as a consequence. Another consequence of thrombosis is what's known as embolism. Okay, an embolism is when emboli travel from the bloodstream from one site to a distant site. So a thrombus can become an embolus. So here's a thrombus in the bloodstream, and when it starts to travel through the bloodstream, then it's called an embolus. And the whole process of that traveling through the bloodstream is called embolism. So what happens with the embolism? Well, this embolus can cut off the blood supply in distant sites and have the same consequences as thrombosis. I do want to point out, though, that not all thrombi become emboli, and not all emboli are thrombi, because an embolus can be any particulate object that's transported in the bloodstream. So as I said, it can be a thrombus that's become mobile, as shown in the illustration. It could be some patients that have arteriosclerosis. They have these plaques forming in the walls of those blood vessels. They can break off and travel through the circulation as emboli. Also air, a big air bubble in the bloodstream is classified, or if someone was shot and a bullet fragment was traveling through the circulation, that also is classified as an embolus. So what are the consequences of embolism? A more common application of this is when someone that's may be bedridden, or even it can happen to from taking a long air flight. What can happen is thrombi can develop in the deep leg veins, and they can travel as emboli to the lungs, and that's referred to as pulmonary embolism. And the person may manifest having, signs of difficulty in breathing because of these blood clots that have moved to the lungs. Okay, another thing that can happen is when in the head and neck area, when there are fatty plaques that build up in the carotid arteries, they can be blocked. And then what can happen is it can spread to the brain. The blood supply to the brain is cut off, and the person can have a stroke, or in other words, a cerebral infarct. It's going to be the same consequence as the thrombus in the heart. What's going to happen is it's going to cut off the blood supply. There's going to be anoxia, and part of the brain can die. And remember, that's the type of necrosis that occurs would be the liquefaction. So these are, two basic consequences, three consequences overall that can happen with heart attacks, pulmonary embolism, and fatty plaques in the carotid arteries traveling to the brain and blocking the blood supply to certain areas of the brain. Okay, the final thing I'm going to talk about in this section is ischemia. Okay, and earlier I pointed out that when there's decreased oxygen to the tissue, that leads to ischemia. in that affected area. So what that is you have this temporary deficiency. So you have like a hypoxic event going on in the tissue, which can be reversible. It says it's temporary. And I mentioned some patients have angina, and one of you may have presented this under medical histories last semester, but some patients have angina where I mentioned earlier that due to hypoxia, decreased oxygen, which can occur when they have partial blockage to their coronary arteries, and then they exert themselves too much or they're under a great deal of stress, they may have an angina attack. And this ischemia is occurring in the heart, and they're getting chest pains. And what they do to relieve this is, take nitroglycerin to open up those coronary arteries and replenish the oxygen supply. If the nitroglycerin doesn't work, this angina attack could lead to myocardial infarction or a heart attack. If we have hypoxia, go to anoxia for a long enough period of time. In the brain, some patients are said to have a TIA, not a full-blown stroke, but these transient ischemic attacks, that they might just have this temporary deficiency of oxygen to the brain. And they may just be briefly confused for a couple seconds. But what can happen then is that the oxygen resumes coming to the brain and they don't end up having a full-blown stroke. Okay, so again, to distinguish ischemia from infarction, let's just kind of look at this final flow chart to sum this up. So if you have, first of all, this right here, we have just a hypoxia, decreased oxygen, that can lead to ischemia. But again, if the oxygen supply is resumed, I gave the example of angina, the nitroglycerin opens up the coronary arteries and that ischemia reverses back to normal. Or if a person's having a TIA in the brain, that's reversible. But if that hypoxia becomes anoxia, deprivation of oxygen for a longer period of time, that can lead to infarction, a myocardial infarction, or as in a heart attack, or a cerebral infarction as in a stroke. If you notice, that is not reversible once infarction occurs. Okay, and then inflammation is another underlying tissue response that we're going to have an entire topic. Okay, I know you've been bombarded with a plethora of definitions and examples, but this is, you just have to know these definitions and these distinguishing features along with the various examples. And next Wednesday, we will be having a quiz on just this topic. I know I was going to be starting, I know we have 20 minutes left, but I am just going to stop right here and we'll finish inflammation and repair next week. And if I don't finish it, I will record the rest of it, but I just want to stop for right now. Before we sign off, does anybody have any other questions?
Yes, how many questions will be the quiz?
Well, it'll probably be like last semester where there, roughly 25 to 30 questions on the quizzes. Yeah, just like,
Okay, thank you.
sure,
The test is going to be on the entire introduction to pathology outline.
yes.
Okay. Thank you.
All right, well, have a good rest of the day and take care.